Two common inflammatory skin conditions in newborns, neonatal cephalic pustulosis and seborrheic dermatitis, offer excellent examples of how pathophysiology guides both diagnosis and treatment. Neonatal cephalic pustulosis, previously known as neonatal acne, typically presents within the first month of life as erythematous papules and pustules on the face. While it was once attributed to maternal hormones, current research shows that Malassezia species, a fungal component of normal skin flora, drives the inflammatory response. In susceptible infants, Malassezia colonization triggers localized inflammation, explaining why Wright's stain shows neutrophils rather than eosinophils. This is a response to microbial colonization, not an allergic reaction. This understanding informs management. Since Malassezia is the culprit, topical antifungals like ketoconazole may speed resolution, although most cases resolve spontaneously within weeks. Cultures aren't needed because Malassezia is part of normal flora. The key to distinguishing this condition from erythema toxicum lies in the Wright stain. Neutrophils point to neonatal cephalic pustulosis, while eosinophils support a diagnosis of erythema toxicum. Seborrheic dermatitis, on the other hand, appears as salmon pink patches with greasy yellow scaling, often involving the scalp, face, and diaper area, regions of high sebaceous gland activity. It typically begins between 2 to 4 weeks of age when sebaceous gland function increases. The pathophysiology includes dysregulated lipid production and Malassezia overgrowth in these lipid-rich areas. The waxy scale helps distinguish seborrheic dermatitis from other skin conditions. While parents may be concerned about cradle cap, reassurance is usually appropriate, as most cases resolve by 1 year without treatment. However, persistence beyond infancy or progression to more extensive skin involvement may signal atopic dermatitis. Studies suggest that infants with seborrheic dermatitis have an increased risk for developing atopic dermatitis later, underscoring the value of documentation and follow-up. Harlequin color change and acropostylosis of infancy represent distinctly different physiologic mechanisms, yet both require recognition to avoid unnecessary intervention. Harlequin color change creates a dramatic visual presentation. The infant suddenly develops deep erythema on one side, while the contralateral side appears strikingly pale. This demarcation follows the midline precisely, creating a split-body appearance that alarms parents and staff. The pathophysiology involves immature hypothalamic control of peripheral vasomotor tone. Position changes often trigger episodes, with the dependent side becoming erythematous due to gravitational blood pooling, while the upper side blanches from compensatory vasoconstriction. Preterm infants demonstrate this phenomenon more frequently due to greater autonomic instability. Episodes last minutes and resolve spontaneously with position change or spontaneous vasomotor rebalancing. The key diagnostic feature, complete resolution without residual changes, distinguishes this from pathologic vascular conditions. No diagnostic workup is needed when the classic pattern appears in an otherwise well infant. Documentation should emphasize the benign nature and expected resolution with neurologic maturation. Acropostylosis of infancy presents an entirely different challenge. Intensely pruritic vesiculopustular lesions on the hands and feet characterize this condition, which disproportionately affects African American, Hispanic, and Asian children. The pathophysiology remains incompletely understood, but 50% of cases follow scabies infestation, suggesting a hypersensitivity response to mite antigens. The intense pruritus distinguishes acropostylosis from other neonatal pustular conditions. Infants demonstrate significant distress, with scratching leading to secondary changes. Wright's stain shows neutrophils and occasionally eosinophils, reflecting the inflammatory nature. When post-scabiatic etiology is suspected, careful examination for residual burrows and family member evaluation becomes essential. Treatment focuses on symptom control with topical corticosteroids for inflammation and antihistamines for pruritus. The condition follows a chronic, relapsing course over months to years, requiring parental preparation for this extended timeline. The ability to rapidly differentiate benign from concerning neonatal skin lesions directly impacts clinical decision-making and resource utilization. Understanding a pathophysiologic basis for each condition enables appropriate triage and management. Benign conditions share common features. They occur in well-appearing infants, lack systemic symptoms, and resolve without intervention. Erythema toxicum, pustular melanosis, milia, miliaria, neonatal acne, and seborrheic dermatitis all represent variations of normal neonatal skin adaptation. Their pathophysiology involves either blocked structures, milia, miliaria, benign inflammatory responses, erythema toxicum, pustular melanosis, or interactions with commensal organisms, neonatal acne, seborrheic dermatitis. These mechanisms explain why cultures remain sterile and systemic symptoms absent. Concerning conditions stem from true infections requiring prompt recognition and treatment. Herpes simplex virus creates grouped vesicles on an erythematous base, often accompanied by systemic illness. The viral cytopathic effect produces multinucleated giant cells visible on zinc preparation. Bacterial infections, whether staphylococcal or streptococcal, generate pustules containing pathogenic organisms and inflammatory cells. Candidiasis produces satellite papulopustular lesions around areas of confluent erythema, particularly in intertriginous zones. Clinical warning signs mandate immediate evaluation. Fever, lethargy, and poor feeding indicate systemic involvement requiring cultures and empiric treatment. The well-appearing infant with tricky benign lesions needs only observation, while any deviation from expected patterns warrants investigation. Wright's stain provides rapid bedside differentiation. Eosinophil predominance confirms erythema toxicum, allowing confident reassurance. Neutrophils appear in multiple conditions: pustular melanosis, neonatal acne, and bacterial infections, requiring clinical correlation. The presence of neutrophils in a febrile infant demands cultures and treatment, while the same finding in an afebrile infant with typical pustular melanosis morphology requires only observation. This diagnostic framework prevents both undertreatment of serious infections and overtreatment of benign conditions. Each clinical decision stems from understanding the underlying pathophysiology and expected disease course. The classification of vascular anomalies into tumors versus malformations represents a fundamental concept that drives both diagnosis and management strategies. This distinction, established by the International Society for the Study of Vascular Anomalies, relies on cellular behavior and natural history rather than appearance alone. Vascular tumors demonstrate endothelial cell proliferation, meaning these lesions actively grow through cellular multiplication. Infantile hemangiomas exemplify this category, representing the most common tumor of infancy, with an incidence of 4 to 5%. The proliferative nature explains their characteristic growth pattern, absent or minimal at birth, followed by rapid expansion during the first year of life. This cellular proliferation eventually undergoes apoptosis, leading to involution. Understanding this growth-involution cycle proves essential for counseling families and determining intervention timing. Vascular malformations represent developmental errors in vascular morphogenesis. These lesions contain dysplastic vessels without endothelial proliferation. Port wine stains, venous malformations, and arteriovenous malformations fall within this category. Present at birth, these lesions grow proportionally with the child, rather than demonstrating the proliferative phase seen in hemangiomas. The stable endothelial cell population explains why these lesions persist throughout life without spontaneous regression. This classification system directly impacts clinical decision-making. A rapidly growing vascular lesion in a 3-month-old suggests infantile hemangioma, warranting observation or treatment based on location and complications. Conversely, a vascular lesion present at birth that grows proportionally indicates a malformation, requiring different counseling regarding natural history and treatment options. The proliferative versus stable cellular behavior determines whether families can expect eventual resolution or need preparation for lifelong management. Infantile hemangiomas demonstrate predictable epidemiologic patterns and growth characteristics that guide clinical recognition and prognostication. Understanding these patterns enables accurate diagnosis and appropriate family counseling regarding expected outcomes. The demographic risk factors, female predominance, prematurity, low birth weight, and firstborn status, suggest both hormonal and placental influences. The 3-to-1 female predominance points to estrogen's role in angiogenesis. Premature and low birth weight infants show increased incidence, possibly related to hypoxic stimuli triggering compensatory vascular proliferation. These associations help identify high-risk populations, requiring careful skin surveillance during early infancy. Clinical classification based on depth determines both appearance and treatment considerations. Superficial hemangiomas involve the papillary dermis, creating the characteristic bright red, strawberry appearance. The superficial location allows visualization of proliferating vessels, explaining the intense red coloration. Deep hemangiomas extend into the reticular dermis and subcutaneous tissue, where overlying skin obscures the vascular proliferation, resulting in a blue or violet hue with normal overlying skin. Mixed lesions combine both components, often presenting as raised red lesions with deeper blue components. The triphasic growth pattern defines infantile hemangioma's natural history. The proliferative phase spans birth to 12 months, with most rapid growth occurring between 2 and 4 months. During this phase, endothelial cells demonstrate increased mitotic activity and expression of proliferative markers. The involuting phase begins around 1 year, marked by endothelial apoptosis and progressive fibrofatty replacement. This process continues through approximately 5 years, though variation exists. The involuted phase represents the end stage, with 50% of lesions substantially resolved by age 5 and 90% by age 9. This predictable natural history provides crucial prognostic information. Parents benefit from understanding that most hemangiomas will resolve without intervention, though the timeline spans years rather than months. Documentation of growth patterns helps distinguish hemangiomas from other vascular lesions and guides decisions regarding intervention timing. While most infantile hemangiomas follow a benign course, recognizing high-risk features and potential complications determines which lesions require intervention versus observation. The pathophysiology of complications directly informs management strategies. Ulceration represents the most frequent complication, affecting 30% of hemangiomas. The rapid proliferation during early growth phases outpaces vascular supply, leading to central necrosis and breakdown. Ulcerated hemangiomas cause significant pain, increase infection risk, and may result in permanent scarring. The inflammatory cascade triggered by ulceration can paradoxically accelerate proliferation at wound edges. Management requires aggressive wound care, pain control, and often systemic therapy to halt proliferation. Pulsed dye laser therapy targets superficial vessels, reducing pain and promoting re-epithelialization. Location determines complication risk and urgency of intervention. Periorbital hemangiomas threaten vision through multiple mechanisms: direct globe compression, induced astigmatism, or amblyopia from visual axis obstruction. Even small periorbital lesions warrant ophthalmologic evaluation and consideration of systemic therapy. Airway hemangiomas, particularly subglottic lesions, present with biphasic stridor during the proliferative phase. The critical nature of airway compromise mandates early recognition and treatment. Large segmental hemangiomas, especially facial lesions, associate with systemic anomalies. Face syndrome, posterior fossa malformations, hemangiomas, arterial anomalies, cardiac defects, and eye abnormalities. Occurs with large segmental facial hemangiomas exceeding 5 centimeters. The association likely reflects shared developmental field defects during early embryogenesis. Recognition of this syndrome necessitates comprehensive evaluation, including brain MRI, echocardiography, and ophthalmologic examination. Propranolol has revolutionized hemangioma management since its serendipitous discovery in 2008. This non-selective beta blocker induces vasoconstriction, decreases expression of vascular growth factors, and triggers endothelial cell apoptosis. The multimodal action explains the rapid response, often seen within days of initiation. Treatment typically continues through the proliferative phase, with most practitioners maintaining therapy until 12 to 15 months of age. Baseline cardiac evaluation and monitoring for hypoglycemia, particularly in premature infants, ensures safe administration. The majority of infantile hemangiomas require only observation and parental reassurance. Understanding which lesions need intervention, based on location, growth pattern, and complications, prevents both undertreatment of high-risk lesions and overtreatment of benign cases, destined for spontaneous resolution. Port wine stains represent congenital capillary malformations that demand careful evaluation due to their potential systemic associations. Understanding their pathophysiology helps explain both their clinical behavior and why certain locations raise immediate concern. These lesions result from a developmental error in neural regulation of dermal capillaries, leading to permanent capillary dilation. The affected vessels lack normal sympathetic innervation, preventing vasoconstriction and creating the characteristic appearance. This vascular malformation affects approximately 3 in 1,000 newborns, appearing as flat, red to purple patches that maintain skin surface texture. The key diagnostic feature, failure to blanch with pressure, reflects blood permanently pooled within dilated capillaries rather than normal perfusion that temporarily clears with compression. The natural history differs fundamentally from hemangiomas. Port wine stains grow proportionally with the child, maintaining their relative size and distribution. However, the pathophysiology predicts their evolution over decades. Without normal vascular tone regulation, progressive vessel dilation occurs. By adulthood, many lesions develop nodularity and cobblestone texture as vessels become increasingly ectatic. This progression from flat patches in infancy to thickened nodular plaques in adulthood helps families understand why early laser intervention, while not curative, may minimize long-term cosmetic impact. Location determines clinical significance. When port wine stains involve the trigeminal nerve distribution, particularly the ophthalmic division, immediate comprehensive evaluation becomes mandatory. The embryologic basis for this association involves the shared developmental origin of facial vasculature and intracranial structures. The proximity of developmental fields explains why facial capillary malformations may accompany ipsilateral leptomeningeal vascular anomalies. Recognition of high-risk facial patterns, particularly those involving the forehead, upper eyelid, or bilateral facial involvement, triggers systematic evaluation for associated anomalies rather than dismissing these as simple birthmarks. Sturge-Weber Syndrome illustrates how embryology informs recognition and management of neurocutaneous syndromes. A somatic activating mutation in GNAQ during early embryogenesis affects tissues from the cephalic neural crest, explaining the syndrome's characteristic distribution. The classic triad includes a facial capillary malformation, port wine stain, leptomeningeal angiomatosis, and glaucoma, all linked by shared embryologic origin. A V1 distribution port wine stain signals risk of deeper vascular malformations. Leptomeningeal angiomatosis on the same side causes venous stasis and cortical hypoxia, leading to seizures, typically starting in infancy. Glaucoma results from elevated episcleral venous pressure, impairing aqueous humor drainage. It can present early with ophthalmos, or later with subtler findings, making lifelong screening essential. Risk stratification depends on stain location. Forehead and upper eyelid involvement indicates high risk for CNS and ocular complications. Bilateral stains suggest near certain CNS involvement. Isolated V2 or V3 involvement carries lower risk. Diagnosis includes early ophthalmologic evaluation and MRI with contrast to detect leptomeningeal enhancement, which may not be visible until after 6 months. CT shows tram tract calcifications later on, reflecting chronic venous injury. Management targets each component: anticonvulsants for seizures, laser therapy for cosmetic treatment of port wine stains, and medical or surgical treatment for glaucoma. Because vascular-induced brain injury is progressive, early diagnosis and multidisciplinary care are key to improving outcomes. Families should understand the need for ongoing monitoring, even in stable periods. Café-au-lait macules represent one of the most important cutaneous markers in pediatrics, serving as potential indicators of underlying neurocutaneous syndromes. Understanding their significance requires recognizing both their common occurrence and the critical threshold that triggers comprehensive evaluation. These light brown, well-demarcated patches derive their name from their coffee with milk coloration. The pathophysiology involves localized increases in melanocyte activity and melanin production within the basal layer of the epidermis without an increase in melanocyte number. This explains why these lesions appear as flat color changes without textural alterations. The oval shape with smooth borders helps distinguish café-au-lait macules from other pigmented lesions, though early lesions may show irregular borders that smooth over time. Size criteria vary with age, reflecting proportional growth patterns. In infants, macules exceeding 0.5 centimeters warrant documentation, while the threshold increases to 1.5 centimeters in children. This size distinction matters because smaller pigmented lesions often represent simple freckles or other benign pigmentation variants. The measurement should occur along the longest axis, and careful documentation of both size and number proves essential for longitudinal monitoring. The critical clinical rule, 6 or more café-au-lait macules necessitate evaluation for Neurofibromatosis Type 1, represents one of the highest yield concepts for certification exams. This threshold wasn't arbitrary, but emerged from population studies showing that while isolated café-au-lait macules appear commonly, multiple lesions strongly correlate with NF1. The timing of appearance varies, with some present at birth, while others develop during the first years of life. This explains why initial normal examination doesn't exclude later development of diagnostic criteria. Demographic variations in prevalence require consideration during evaluation. While 2% of white individuals have at least one café-au-lait macule, this increases to 12% in African Americans. This six-fold difference in baseline prevalence doesn't change the diagnostic threshold for NF1 evaluation, but helps contextualize findings in different populations. The predilection for appearing over the buttocks in neonates provides a high-yield examination tip. Always check this area during newborn assessments, as lesions here may be overlooked. The diagnostic criteria for Neurofibromatosis Type 1, NF1, provide a validated framework reflecting the multi-system nature of this autosomal dominant disorder. Understanding how each criterion contributes to diagnosis helps guide clinical recognition and counseling. The requirement for 2 or more criteria accounts for NF1's phenotypic variability, even among individuals with identical mutations. This variability stems from the tumor suppressor role of the NF1 gene. Loss of neurofibromin affects multiple tissues, but specific features depend on additional genetic and environmental factors. Café-au-lait macules are often the earliest sign, present at birth or within the first year. The size cutoffs ensure accurate identification, and having 6 or more appropriately sized macules is nearly pathognomonic, though a second criterion is still required for diagnosis. Axillary or inguinal freckling, crow's sign, emerges between ages 3 and 5, resulting from the same melanocyte dysregulation, but in areas of friction. Its specific location distinguishes it from sun-induced freckles and explains delayed onset, often limiting diagnosis in infancy. Neurofibromas, the hallmark lesions, arise from Schwann cell proliferation following a second hit mutation. 2 or more neurofibromas, or one plexiform neurofibroma, meet criteria. Plexiform types may be congenital and carry malignant potential, making them especially significant. Optic pathway gliomas affect about 15% of patients, usually presenting before age 6. Though often asymptomatic early, they require serial ophthalmologic monitoring. Their presence confirms diagnosis and signals the need for vision surveillance. Lish nodules, melanocytic hamartomas of the iris, are best seen by slit lamp exam. They increase with age and are present in over 90% of affected adults, making them a helpful diagnostic feature in older children and adults. Skeletal lesions, such as sphenoid wing dysplasia and tibial pseudarthrosis, reflect neurofibromin's role in bone development. Though rare, they are highly specific and diagnostically valuable when present. Finally, a first-degree relative with NF1 satisfies diagnostic criteria due to its autosomal dominant inheritance and complete penetrance. About half of NF1 cases result from de novo mutations, so family history may be negative. Recognizing this helps enable early diagnosis and surveillance in at-risk children. By viewing the criteria as an integrated whole, rather than isolated signs, clinicians can better manage NF1 and counsel families regarding its progression and complications. Dermal melanocytosis represents one of the most common pigmented birthmarks, yet its pathophysiology and clinical significance remain frequently misunderstood. These lesions demonstrate striking demographic variations that reflect underlying genetic differences in melanocyte migration patterns. The pathophysiology involves arrested migration of melanocytes during fetal development. Rather than completing their journey to the dermal-epidermal junction, these melanocytes remain trapped within the dermis. The Tyndall effect, selective absorption and scattering of light by dermal melanin, creates the characteristic blue-gray appearance. Longer wavelengths penetrate to the dermal melanocytes, while shorter wavelengths scatter, producing the bluish hue. This optical phenomenon explains why dermal melanocytosis appears blue despite containing brown melanin pigment. Demographic prevalence correlates with baseline skin pigmentation: 90% in African Americans, 81% in Asians, and only 10% in whites. This distribution suggests genetic factors controlling melanocyte migration velocity and timing. The classic lumbosacral location reflects the embryologic pattern of melanocyte migration from neural crest, with the lower back representing one of the last areas to receive migrating cells. When migration arrests occur, these terminal zones show the highest concentration of retained dermal melanocytes. The natural history follows predictable patterns. 42% of lesions fade by 1 year as dermal melanocytes gradually disappear through unknown mechanisms. Most remaining lesions continue fading throughout childhood, though some persist into adulthood. The resolution process doesn't require intervention. These trapped melanocytes pose no malignant potential and cause no functional impairment. Documentation carries medical legal importance that extends beyond routine clinical care. The blue-gray discoloration, particularly when extensive or in unusual locations, may be mistaken for bruising by those unfamiliar with this benign condition. Detailed documentation including location, size, and characteristic blue-gray color prevents false abuse allegations. Photographs provide additional protection, especially for extensive lesions. Parents benefit from understanding this documentation necessity and receiving written information about dermal melanocytosis to share with other caregivers. No imaging or biopsy is indicated. The clinical appearance in the appropriate demographic context confirms the diagnosis. Hypopigmented lesions in newborns demand careful evaluation due to their potential association with tuberous sclerosis complex, a multi-system genetic disorder with significant neurologic implications. Understanding the pathophysiology helps distinguish benign variants from markers of systemic disease. Ash-leaf macules, named for their resemblance to the European mountain ash leaf, represent the earliest cutaneous manifestation of tuberous sclerosis. These oval or leaf-shaped hypopigmented patches result from decreased melanin production despite normal melanocyte numbers. The mechanistic link involves hamartin and tuberin, the protein products of TSC1 and TSC2 genes, which regulate melanogenesis through the mTOR pathway. Mutations disrupting this pathway affect melanin synthesis, creating the characteristic hypopigmentation. The diagnostic threshold, 3 or more hypopigmented macules exceeding 5 mm, reflects careful epidemiologic studies. While isolated hypopigmented patches occur commonly, multiple lesions strongly associate with tuberous sclerosis. Wood's lip examination enhances visualization by accentuating the contrast between normal and hypopigmented skin through its 365 nanometer wavelength that highlights melanin differences. This tool proves especially valuable in fair-skinned infants where subtle hypopigmentation might otherwise be missed. The significance of identifying ash leaf macules extends beyond dermatologic diagnosis. Tuberous sclerosis follows an age-dependent expression pattern. Cutaneous findings precede neurologic manifestations. Seizures, often infantile spasms, typically begin within the first year. Developmental delays become apparent as cognitive demands increase. Facial angiofibromas emerge later, usually after age 3. This temporal progression means that recognizing ash leaf macules enables early diagnosis before irreversible neurologic damage occurs. Evaluation of infants with multiple hypopigmented macules requires systematic assessment. Baseline electroencephalography may detect subclinical seizure activity. Brain MRI identifies cortical tubers and subependymal nodules before clinical symptoms develop. Ophthalmologic examination reveals retinal hamartomas. Renal ultrasound screens for angiomyolipomas. This comprehensive evaluation, triggered by cutaneous findings, allows early intervention that may modify disease trajectory. Differential diagnosis includes nevus depigmentosus and hypomelanosis of Ito. Nevus depigmentosus presents as a solitary, stable hypopigmented patch with irregular but well-defined borders. Hypomelanosis of Ito creates whorled or linear hypopigmentation following Blaschko's lines, often associated with systemic abnormalities. These conditions lack the oval morphology and multiplicity characteristic of ash leaf macules. The Wood's lamp examination helps distinguish subtle differences. Congenital melanocytic nevi present a unique challenge in newborn care due to their variable cancer risk and cosmetic concerns. Understanding how size and tissue involvement relate to malignant potential helps guide both counseling and management. These lesions form during fetal development when melanocytes proliferate abnormally, creating what we call hamartomatous nevi. They often extend deeper into the skin than acquired moles. The process is driven by somatic mutations, especially in the NRAS and BRAF genes, which occur after fertilization. That's why these nevi are present at birth but don't run in families. Their depth, often reaching through the dermis into subcutaneous fat, explains why they persist and why superficial treatments usually don't work. We classify congenital melanocytic nevi by size, and this classification directly informs their cancer risk. Small nevi, defined as less than 1.5 centimeters in diameter, have a very low risk, less than 1% over a lifetime. Medium-sized nevi, between 1.5 and 20 centimeters, carry a slightly increased risk. Large or giant nevi, those greater than 20 centimeters or covering a significant portion of the body, carry a much higher risk, estimated between 4.5 to 10%. The increased risk in large nevi comes from two factors: the sheer number of melanocytes and the greater likelihood of accumulating additional mutations. Melanoma can arise within the nevus itself, or, in rare cases, in melanocytes located elsewhere, particularly in the central nervous system, a condition known as neurocutaneous melanosis. During examination, clinicians should document the nevus's size, color variation, texture, and presence of hair. Terminal hair, the thick, coarse type, suggests deeper dermal involvement and helps distinguish congenital nevi from acquired ones. While color variation and irregular surfaces may be concerning in typical moles, they are often benign features in congenital lesions. Management depends on both risk and feasibility. For small nevi, observation is typically enough. Annual photography helps monitor for changes. Parents should be taught the warning signs: changes in symmetry, border, color, size, or new symptoms like bleeding or itching. Medium-sized nevi may be removed depending on location, growth, or family preference. Large or giant nevi often require a more complex approach. Prophylactic surgical removal can lower cancer risk, but full excision usually involves multiple staged procedures and carries a risk of scarring. Because these lesions extend so deep, surface-level treatments are rarely effective. Ultimately, optimal care involves a multidisciplinary team, usually including dermatology, plastic surgery, and oncology, to create a personalized plan that addresses both safety and quality of life. Several birthmarks and skin tumors in infancy require recognition due to their potential for complications or association with systemic conditions. Understanding their pathophysiology supports accurate diagnosis, management, and family counseling. Nevus sebaceous is a hamartoma containing underdeveloped sebaceous glands and hair follicles. These yellow waxy hairless plaques typically appear on the scalp. In infancy, they remain flat and subtle. At puberty, hormonal stimulation causes thickening and deepening of color. The major concern is that 10 to 15% develop secondary tumors. Most are benign, such as syringocystodenoma papilliferum or trichoblastoma, but basal cell carcinoma risk rises with age. This modest malignant potential supports prophylactic removal before puberty, when lesions are smaller and more easily excised. Aplasia cutis congenita presents as a localized absence of skin, usually on the scalp vertex. It likely results from vascular compromise or incomplete neural tube closure. Most lesions appear as a single, well-defined ulcer or smooth scar. The key finding is the hair collar sign, a ring of coarse, dark hair surrounding the defect. This may indicate underlying neural tube defects or atopic brain tissue. Abnormal closure traps neural tissue at the surface while stimulating nearby hair growth. When this sign is present, neuroimaging is required before any intervention to avoid injury to brain tissue. Juvenile xanthogranulomas are yellow-orange papules caused by reactive histiocytic proliferation. They usually appear in the first year of life and resolve on their own over time. These are not true tumors, and no treatment is needed. Biopsy is rarely necessary. The main concern is eye involvement in infants with multiple lesions, which calls for ophthalmologic screening. Mastocytosis involves excess mast cell growth. In children, this often appears as a solitary mastocytoma, a tan-brown plaque or nodule. The classic Derrier sign occurs when rubbing the lesion triggers redness and swelling due to histamine release. These localized lesions differ from systemic mastocytosis. Management focuses on avoiding triggers, such as friction or certain medications. Families should be aware of rare systemic symptoms like flushing or low blood pressure. Most cases resolve by adolescence, with antihistamines used if needed for itching or reactivity.